Welcome, everybody. It's my pleasure to welcome you to this event, which is called Unveiling Obstetric Violence, Ethnographic Insights and Structural Determinants. This talk is going to be held by our colleague, Carol Pizzuti. Before starting, I'd just like to introduce you to our club, the organizers of this talk. I don't know if you might already be familiar with us, but in any case, I'd like to remind you that the Applied Club Health is a community that was created for those interested in finding solutions to improve health and healthcare by employing an applied anthropology perspective. We strive to provide an open space to talk, meet, network, and exchange ideas, best practices, resources, and opportunities. eHealth is part of a wider applied anthropology network, which is based in Europe and does lots of different activities. In some of the links that we shared in the chat, you can find also the link to the website, so you can explore more what this organization is. We welcome you to also sign up for our newsletter because we cover lots of different topics in applied medical anthropology. And we've got a lot coming up in the next months that you might be interested in. We also got our past events on YouTube if you'd like to catch up on what we did for the past year. We're only 1 year old and we've done a lot already. So reason of pride. I'd like to ask my fellow organizers to just give a little wave to our participants and maybe just unmute yourself to say your name, just so that you can be visible in the chat. In the meeting.
I'm Heinrich. Hello.
Hi, I'm Margaret from Austria.
Hi, I'm Mirko. Hello.
And hello, everyone. I'm Carol from Australia.
Amazing. You're from Italy, don't lie. You're just based in Australia, because I'm also from Italy.
Based in Australia.
Okay, so don't say more, Carol, because I'd like to introduce yourself, because Carol is actually the speaker for today. So Carol is a medical anthropologist that specializes in women's sexual and reproductive health issues. She currently works as Senior Research Officer at the Royal Australasian College of Physicians in Sydney, Australia, and has just completed her industry PhD in the field of practice analytics in healthcare, PAH, which focuses on exploring the use of eHealth data analytics for medical practitioners continuing professional development. So I'd like to say a couple of words about the talk of today. So, growing from ethnographic research that was conducted in Italian public hospitals and community health center settings, today Carol will present the nuanced manifestations of obstetric violence and its intersection with structural determinants. Beginning with an exploration of childbirth pain as a research entry point, she will share reflections on the challenges encountered in uncovering women's experiences and perspectives around pregnancy, childbirth, and postpartum. Particularly the resistance faced in acknowledging obstetric violence as a legitimate concern by both academia and industry. Carol will conclude by offering practical insights on how to apply these findings to advocate for systemic change within contemporary medical practice. So I think we all agree it's extremely interesting, the topic that we're going to discuss today. And before I leave the floor to Carol, I'd just like to remind a few housekeeping things. So the discussion is going to be followed by a Q&A or more like an open discussion in which everybody is very much invited to share their thoughts and questions. And if you have any thoughts that pop up in your mind as Carol is speaking, we welcome you to write them in the chat or also on the Padlet, which you also have the opportunity to ask questions anonymously. The Padlet's link was pasted in the chat by Harry a few minutes ago. So without further ado, I'm just going to leave the floor to Carol and yes, enjoy.
Thank you so much, Gaia. So first things first, I will share my screen with you all and just let me know if it doesn't work and I will try to address that. Can you see it? Perfect. So thank you very much, everyone, for being here, and thanks, Gaia, for the amazing presentation. As Gaia mentioned before, today I'm going to briefly present my ethnographic insights about the research that I have done during my Master's of Research in Italy years ago. And I will focus on my specific insights, of course, and also I will have a look at the structural determinants that are behind some of the occurrences of obstetric violence nowadays. So I would like to start, first of all, by acknowledging the Gadigal of Eora Nation, the traditional custodians of the land on which I am presenting today, and I pay my respects to the elders past and present. As a second point, before we start officially with the presentation today, I really would like to make sure that if at any point during this presentation, the topic causes you any kind of discomfort and you feel that you might need support, please don't hesitate to reach out using these numbers. So I have added the Australian one because I am based here in Australia, in Sydney, and the Italian one because I am familiar, of course, with the country. I come from Italy, and also because the research was conducted there. What I would like to ask you, if you could please share any kind of number or contact that you know about the country you come from in the chat, please, because of course sharing is caring, and if we can support our fellow humans, I think it's always very much appreciated. I would like to start with a very generic definition or description of what obstetric violence is. So in the literature, there are different definitions and understanding, depending on the context, of course, social determinants, institutions, and a country. I usually refer to obstetric violence using a very generic definition. And I talk about it when we are experiencing or there is an occurrence of any form of mistreatment or abuse that occurs during pregnancy, childbirth, or the postpartum period. Some other important points are the following. So obstetric violence can include actions or practices that undermine a woman's autonomy, dignity, or ability to make informed choices about her own body and health during pregnancy, childbirth, or the postpartum period. Something very important to remember also is that these actions and practices can lead to feelings of disempowerment, trauma, and violation among those who experienced it. And a very important point that we will return on several times today is that obstetric violence can arise because of structural determinants within healthcare systems and broader societal factors, including power imbalances, institutional policies and practices, and societal and cultural norms and attitudes. And we will look into this a little bit more tonight. Even though obstetric violence has different forms, what I am going to do today is to give more attention to my individual ethnographic fieldwork. And I will start with giving you some context about the time frame, the locations, and also the informants of my research. So this piece of research happened a long time ago, between June 2009 and July 2011. And of course, to give you more context, I would like to share with you where my fieldwork was conducted. So you can see here the map of Italy and all these little pins in red. And more or less, that's the area of Rome. And within the region of Lazio, it's where Rome is. I had the chance to do my fieldwork in 5 different locations, and 3 of them were public hospitals, and 2 of them were community health centers. In Italian, they are called consultorio familiare because in these healthcare service organizations, the most important thing is to provide support in terms of sexual and reproductive health, especially to women. Something more about the location that I think it's important to remember is that all the hospitals in which I conducted research were public. So of course, this is an important piece of information. And the first one, the number one that you see, called Belcolle Hospital, is very important because it's considered as a center of excellence for those women who tries to have a vaginal childbirth after having experienced a cesarean section. So since in medicine it's considered a high-risk procedure, this hospital is very well known in the area for at least trying to give women an opportunity to experience a vaginal birth instead of undergoing surgery. Some other informations about the field work is about the informants. So I had the chance to talk to 66 people. And these are the types of people I talked to. Of course, pregnant women and new mothers, midwives, nurses, one social worker, and 2 gynecologists. In some cases, I talked to, especially to pregnant women and new mothers multiple times, especially when I worked in the consultorio, so in the community health center, because I had the chance to follow them longitudinally before the childbirth and afterwards. So in the end, the amount of data that I collected is really great. It's really big, and I have more than 66 interviews. I had more than 66 interviews. Something that is interesting also to know about my informants, that all of them were females at birth and identified as women. And this is important to understand because this happened for two main reasons. First of all, in most of the cases, the health professionals around pregnant women and new mothers, at least in my field work, were females. I encountered just 2 or maybe 3 male gynecologists, not more than that, and none of them were interested in participating in my research, even if they were asked. And this, of course, I think highlights one of the peculiarities, I would say, of the field, that sometimes when it comes to sexual and reproductive health of women, sometimes the male counterpart is not very much involved, or at least it's not what I have seen during my field work. And just to be precise in terms of methodology, I would like to share with you that I conducted unstructured interviews with my informants, and I used grounded theory when it came to data analysis. Said this, as Gaia mentioned before, I would like to start with the research entry point for my research, because I think it gives an understanding of also the structural determinants and some of the problems that we have in anthropology as a discipline. So when I was doing my master's degree, I was asked to frame my research in the pain narratives, in the broader frame of illness narratives that comes from the School of Harvard. So of course, being an anthropologist, you know very well what this means. And also, I think you can also foresee slightly why this kind of frame of reference didn't work. I am going to share with you why it didn't work, and it was very easy to understand at the very beginning, even just after a few interviews with my participants. And these are the reasons. So pregnant women and also new mothers, first of all, did not identify as ill or sick, even if sometimes they were navigating gestational pathologies, so diseases. Secondly, pain during labor was labeled by my informants as physiological pain and not as pathological pain, and meaning for them that this kind of pain serves a function, a specific function. And a third point that I would highlight is that for many women, pain during labor was perceived, and I think is still perceived, as having meaning and purpose, because of course their goal was to give birth to their children. So even just looking at these 3 considerations, you can understand very well how a narrative of illness would not work in this case. And this leads to a couple of points about reflexivity and structural determinants. So because when it comes to reflexivity, what I could understand during the first phases of the research was that my research team, or even the professors behind my research, were having specific research assumptions and biases. These three are just some of them. So, for instance, that pregnancy and childbirth are pathological occurrences, that pain is exclusively sensory pain, with no attention for the individual perception of it, and also a very interesting association between childbirth as labor and labor as just pain. This leads us to specific reflections also on structural determinants, because behind these research assumptions and biases, there are specific cultural determinants. And one is the phenomenon of medicalization that pervades our life, and especially sexual, I would say, especially sexual and reproductive health of women. Another one is the women's position in our society. And the third one is the idea or the concept of reductionism, meaning that especially when it comes to the association of childbirth to labor and then labor to pain, we are witnessing a denial of the symbolic and political dimensions of pregnancy and childbirth. So keeping this in mind, of course, what happened to my research was that I had to shift my focus from illness narratives to obstetric violence. And I did so not because there was an intention, a personal individual intention coming from me to pass to obstetric violence, but because I just give importance to the voice of the women. I truly listened to what they were telling me, instead of starting with preconceptions or a specific frame in mind. I would like to share with you now some examples of obstetric violence using the voices and the words of these women to let you understand how obstetric violence can occur and how we can witness it. In most of the cases, I think that out there in the literature, there are examples that are very hard, even, I think, to mention. In my case, I think the occurrences of obstetric violence were a little bit more nuanced. And for this reason, I think that could be generally dismissed as just an abrupt behavior or a little bit of rudeness coming from health professionals, or just, someone having a bad day. But if we look at it from a different perspective, I think that there's much to learn there, especially if we want to intervene and improve healthcare services and medical practice. So I will share with you some experiences in pregnancy, childbirth, and also postpartum. The first one is about pregnancy, and I would like to talk about one of the ways obstetric violence can be seen, and is derision. So we have here of course, the original quotes were in Italian. I translated them for you as best as I could, and we are talking about birth plans. So for those who don't know, birth plans is something that is used very much, I think, nowadays, especially in the most kind of progressive healthcare settings. And they consist of a birth plan, meaning that the woman can plan how she would like to experience the childbirth of her children, what she would like to do, not to do, if she wants to use music, what kind of positions she want to assume during labor, if she wants the support of family or their partner, and also if she wants medications to be used, or even anesthetics, for instance. Something that was very evident during my field work is the fact that sometimes these birth plans are actually completed and filled in, but in most of the cases during the prenatal courses done in community centers, but then they just stay there, they remain there, they are not brought to the hospital when they are admitted, for one reason. That's you can see, that's what you can see in purple here, is that health professionals at the hospitals make fun of them, make fun of the women who brought them. Midwives don't don't take them seriously. And in just not in one hospital, but in different hospitals, I have heard that this is the common reaction coming from health professionals at all levels, which is derision. Of course, in more applied terms, in more practical terms, because we are here also for that, to translate this kind of behavior to someone who is in quality and safety, for instance, in hospitals, or just wants to improve healthcare services, we need to translate it in this way. So what happened gives a clear understanding of what's missing at the health service level, which is shared decision-making, patient-centered care, and cultural responsiveness, for instance, because of course, different people have different cultures, and there's a different culture of birth and pregnancy behind. When it comes to childbirth, another experience is about dismissal. In this case, my informant shared with me that during the labor, she was given, her labor was inducted using oxytocin, but she didn't want to. Despite voicing her choice, the health professionals didn't follow through. And what happened is that the baby started suffering so much, because when oxytocin is given to the woman in labor, the uterus contracts even faster to of course, to make the expulsion quicker. But the point is that sometimes when it happens too fast, the baby starts suffering. And in fact, in this case, the baby's heartbeat was plummeting. There was no oxygen. There was a risk of a cardiac arrest. And what happened was that in the end, because of this, she had to undergo surgery and have a C-section. Even in this case, something that can be seen as obvious, but this is the decision of the health professional. You need to follow what the health professional says because they know better. In this case, if you read the whole quote, this can actually be questioned. And if we need, again, to translate this kind of behavior that can be seen as minimal to someone that needs to improve the quality of the services, I would say that in this case, there was no informed decision-making. The health professionals didn't show ethical responsibility, and also they put at risk the safety of the patients in this case, not just the woman, but also the baby. Something else that is quite common, apparently, during labor, and especially during the very last phase, is to perform episiotomy without adequate anesthesia. So for those who don't know, episiotomy is it's a cut that is done in the tissue between the vaginal opening and the anus during childbirth to allow the baby to basically come out. So a lot of women, and this is not the only one, shared with me that the doctors didn't wait for the anesthesia to work, and they continued to sue. To the extent that in most of the cases, they felt so much pain that it was even more excruciating than the contractions of the labor itself. So in this case, we have, of course, disregard, and some people could see it as just that. But again, if we want to translate it in applied terms to change practices, we should call this kind of episode like a lack of pain management strategies, non-adherence to clinical guidelines, and again, a lack of attention for patient-centered care. Something else that I have heard about, and that happens during labor very often, is denigration, especially in form of verbal abuse. So if you have a look at the quote here, what Michaela is telling us is that basically during the very last phase of the labor, despite the fact that she was trying to do her best, that's what she's saying, a lot of health professionals around her started offending her, calling her a loser, and why she couldn't do it. You don't fight enough. And also, if she was not angry with anyone, why she was not putting the energy to do that. If you just read the very last line, you can hear her voice. She just said, they offended me, it hurt me. And of course, this is this is something we don't want to see, of course, with the patients. And even if someone could think that this is just a motivational speech, it is not, because once again, if we look at practices and behaviors, there is a lack of professionalism here. Again, there's a risk for the safety of the patient, not just on the moment, but in the long term. And also, of course, there could be risk management issues, because this is liable for potentially being brought to court. One last example is about postpartum. I need to be honest, in this case, a lot of women didn't talk about pain, so as a sensory sensation, so pain in the body, but they mentioned many times suffering, and especially about feeling lonely, not supported, both in the family setting and also by health professionals. But in this case, because we need to focus on health professionals' behavior, I would like to point to you the concept of indifference. In most of the cases, a lot of women experienced issues during breastfeeding or trying to breastfeed. And you have an excerpt here, not of an interview, but actually of one of the sessions that I did during the prenatal course in one of the healthcare centers. So it's you can see Christina and Antonella here. One is a pregnant woman and the other one is the midwife. So it seems that Christina, the pregnant woman, was given an information sheet by her hospital about the practices that would be done in neonatology after the baby was born. And as you can see here, this kind of piece of paper said or read that if the quantity of the breast milk is not sufficient, the neonatologist on duty will decide whether to add artificial milk if necessary. So the problem here was that Christina was not happy about that, because she didn't want to give her baby some formula, and there is this nice exchange between the Christina and the midwife, and you can see also how the midwife uses very specific words, that this is a prevarication and it shouldn't happen. Again, even in this case, a lot of people could look at this as, health professionals know better, and this is what it's needed. But if we truly look at what is happening, is that we are ignoring consent in infant feeding. And this means, once again, lack of professionalism, a lack of attention to family-centered care, and also in many cases, also a lack of cultural competency. So you have seen, I have tried to describe to you some of the nuances of obstetric violence, because we know from the literature that out there are very severe cases of a very different nature from the ones that I have just described. But still, I think it's important to highlight this, because they say a lot about what is happening in the Western culture, and in this case, what is happening in what happened in Italy and still happening in Italy. And it says a lot about the cultural determinants behind this, because in most of the cases, we think that it's social determinants, socioeconomical ones, political ones, but there's also a lot of culture. And just to mention some. Of course, obstetric violence is very much influenced, for instance, by the cultural beliefs and attitudes around pain and suffering, by the culture of birth, the culture of medicine, especially when it comes to power imbalances and hierarchy, the culture of medicalization of our society, and also the culture of patriarchy that is still very much present. For instance, when it comes to gender bias or gender roles, the normalization of violence against women, the control of reproductive choices, and also power dynamics. What I would like to share with you are some ideas to move forward. Of course, these are actionable steps, but I really would like to hear from you. The very first one is about having more reflexivity and awareness in our discipline, because I think it starts from our discipline itself sometimes, that we just internalize some of the cultural traits of the culture, of course, that we are embedded in. But this could be potentially dangerous for the way we conduct field work and the way we analyze data. A second point, of course, and I think it was clear when I was talking about all these experiences, is that health professionals should receive a different education and training, much more centered on all the also the cultural determinants that we mentioned before. There is a need for policy reform, and I am very happy to see that in some cases this is happening at the moment. Of course, we need changes in the healthcare system, and probably this is the more difficult one, is that we need a broader societal shift towards respecting women's right and agency in reproductive health. This is a cultural shift, and as anthropologists, I'm sure that we all know how much it is difficult, how difficult it is to change mindsets, attitudes, and the vision of the world. It is everything for me for now, and I really would like to hear what you think and also your experiences. Thank you.